Hello, everyone. My name is Gergana Relenekova, and on behalf of the World Stroke Organization and the World Stroke Academy, I'm pleased to welcome you to this webinar on stroke in women. The webinar will run for an hour, and we are recording. Therefore, it will be available on the website in the next few days. After the presentations, we will have a Q&A session. Please post your questions in the Q&A function at the bottom of your screen. It is my pleasure now to introduce the moderator of the webinar today, Maria Luisa Zede, part of the Neurology Unit Aziende Unità Sanitaria Locale in Reggio Emilia, Italy. Maria Luisa, over to you.
Thanks, Gergana. And first of all, welcome to all of you at this interesting webinar on women and stroke. Actually, I am a vascular neurologist and I am the chair of the WISE group within European Stroke Organization. WISE group is a working group on women and stroke and cerebrovascular disease. And the mission of WISE is to promote, gain, and spread the knowledge about gender differences in stroke, with a special attention to women. Both the speakers of today's webinar are active members of the WISE group. So I am very proud to chair this initiative of World Stroke Organization and World Stroke Academy on such a relevant topic. I'd like to leave the stage to the speakers. I think we can make a general discussion at the end of the two presentations. The first speaker is Professor Anita Arsovska, Head of Department for Urgent Neurology at University Clinic of Neurology, University St. Cyril and Methodius in Skopje, Republic of North Macedonia. She's also the president of the Macedonian Stroke Association, the vice president of SAFE, and World Stroke Academy Associate Commissioning Editor. Professor Arsovska is directly involved in the ESO East Angel projects. She participated in the Stroke Action Plan for Europe as part of the ACT Stroke Management Working Group, and she's very active in promoting stroke prevention and raising stroke awareness. And she will talk us about specific risk factors for stroke in women. Thank you, Anita.
Thank you very much. It is a great pleasure for me to give a talk on specific risk factors for stroke in women at the webinar organized by the World Stroke Organization and the World Stroke Academy. Before I start with my lecture, on behalf of the World Stroke Organization, we would cordially like to invite all of you to join the 13th World Stroke Organization Congress that will be held as a virtual meeting on the 28th and 29th of October 2021. Ana Catarina Fonseca is co-chair of the Scientific Program Committee, and during the Congress, you will have the opportunity to attend highly interactive sessions and meet faculty and delegates from all over the world. This is my disclosure. And I'm going to start with stroke epidemiology data in women. Young women less than 59 years have a similar prevalence of stroke as men. In the higher age groups, more than 80 years, there is a female dominance, mainly due to the higher life expectancy of women. Each year, 55,000 more women than men have a stroke. The stroke incidence in women is 59 per 100,000, which is slightly lower than men. It is 62.8 in men, but the mortality is higher in women. It is 39.2% compared to 26.3% in men. Besides non-modifiable risk factors for stroke, such as age, genetics, and race, There are several modifiable risk factors. Some of them are exclusive to women throughout the lifetime and occur at different ages. I'm going to address several risk factors, such as disparities in the prevalence of certain conventional risk factors, and also specific risk factors such as hormonal disturbances that affect age at menarche and menopause, use of hormone therapy like oral contraceptives, gender-affirming hormone therapy, and hormone replacement therapy, and also periods of pregnancy and postpartum. There are differences in conventional stroke risk factors. Compared to men, hypertension is lower in women in younger age groups, and it is higher in older age groups. In younger age groups, women are more likely to have blood pressure controlled. In older age groups, women are less likely to have blood pressure controlled. Dyslipidemia is lower in women, but women are less likely to be on statins and have LDL controlled. Atrial fibrillation is higher in women, but women are less likely to be prescribed oral anticoagulants, less likely to have cardiac ablation, and they receive lower doses of NOAC. Migraine is a predominantly female disorder affecting women with a ratio of approximately 3:1 to men. The highest one-year prevalence of migraine is between ages of 25 and 55 years, and it is estimated that 22 to 37% of women will experience migraine during their reproductive years. As the association between migraine and ischemic stroke is particularly strong in women with migraine with aura under the age of 45, certain aspects during a woman's life need to be considered. Precise mechanisms by which migraine is linked to stroke are unknown and possibly multifactorial. Cortical spreading depression is the electrophysiological mechanism that underlies migraine aura, where neuronal activation is accompanied by brief hyperperfusion that lasts 1 to 2 minutes, followed by neuronal suppression and hypoperfusion that persists for 1 to 2 hours and corresponds to 20 to 30% reduction of cerebral blood flow. Under normal circumstances, the reduction of CBF is insufficient to cause cell damage. However, on rare occasions, the hypoperfusion may be severe enough to cause ischemia. Migraine with aura is associated with a lower triggering threshold for cortical spreading depression, making the migraine-susceptible brain more vulnerable to cerebral ischemia. The risk of stroke in patients with migraine with aura is increased approximately twice. Women with migraine who also use combined oral contraceptives have a further increased risk of ischemic stroke, where women with migraine with aura who use oral contraceptives and who are active smokers have a dramatically elevated risk for stroke. Women who have migraine with aura should be advised to control all modifiable risk factors, including tobacco use and hypertension, and birth control methods other than oral contraceptives should be considered. Although a contraceptive pill containing 30 micrograms of estrogen is considered safe and effective hormonal contraception, careful attention to stroke risk should be made before prescribing. Non-hormonal and progestogen-only methods of contraception should also be considered in high-risk patients. During pregnancy, there is a significant increase in hormonal activity, significant cardiovascular, hemodynamic, and coagulation changes. All these physiological gestational adjustments can predispose pregnant women to the appearance of cerebrovascular disorders. The reported incidence of stroke varies from 25 to 34 cases per 100,000 deliveries. The rate of stroke is increased by ninefold at the time of delivery and threefold in the early postpartum period, with an increase in the risk of both ischemic and hemorrhagic stroke. Hypertensive disorders of pregnancy, a spectrum that includes gestational hypertension, preeclampsia, and eclampsia, are a leading cause of maternal and perinatal morbidity and mortality worldwide. Eclampsia and preeclampsia are the strongest risk factors for both ischemic stroke and intracerebral hemorrhage, accounting for 24 to 48% of all pregnancy-associated strokes. The risk is potentiated by pre-existing genitourinary tract infection, chronic hypertension, prothrombotic states, and coagulopathies. There is evidence that women with pregnancy outcomes of preterm birth and small for gestational age infants have higher rates of cerebrovascular events even after adjusting for other pregnancy complications. For women with prior stroke, the risk of recurrent stroke is increased in the peripartum and postpartum periods. The absolute risk of recurrent stroke associated with pregnancy is 0.7%, similar to the less than 1% of yearly risk of recurrent stroke among young adults who have no vascular risk factors. The absolute risk depends on the presence of vascular risk factors or a definite cause of stroke, including thrombophilic disorders. The presence of a patent foramen ovale in pregnancy is associated with an increased risk of stroke in individuals with prothrombotic risk factors, including activated protein C resistance and reduced blood levels of protein S. However, in contrast to the risk of stroke from other factors, the risk owing to a patent foramen ovale peaks during the first and second trimesters of pregnancy. Pregnant women with hypercoagulable states should be considered for antithrombotic therapy with low molecular weight heparin. But PFO is not a barrier to normal, healthy delivery. In some studies, earlier age at menarche has been associated with greater cardiovascular disease morbidity and mortality. In the Million Women study from the United Kingdom, a U-shaped relationship between age at menarche and cerebrovascular disease was observed. Women who experienced menarche at age less than 10 years were at higher risk of developing stroke in later life compared with those with age at menarche at 13 years. However, women who experienced menarche at age more than 17 years were also at higher risk of developing stroke compared with those with age at menarche at 13 years. Women with extremely early age at menarche may experience hormonal disturbances, such as higher exposure to estradiol, potentially mediated through childhood obesity. The timing of menarche is associated with type 2 diabetes mellitus risk, an association which may be influenced by childhood adiposity and endocrinopathies. The burden of risk factors for vascular dysfunction increases in women after the menopause, presumably owing to the postmenopausal decrease in estrogen, a hormone with vasoprotective properties. This assumption is consistent with the finding that early menopause increases the risk of stroke. According to a meta-analysis of 300,000, 10,000 women from 32 observational studies, natural onset of the menopause before the age of 45 years increases the relative risk of overall coronary heart disease, overall stroke, cardiovascular mortality, and all-cause mortality. Surgical menopause, bilateral oophorectomy with or without hysterectomy, has also been associated with high risk of CVD. In Nurses' Health Study, bilateral oophorectomy before age of 50 years was associated with increased CVD mortality in women, and especially in women who did not use hormone therapy. Specific mechanisms responsible for the association between the timing of age at menopause and CVD are unclear. However, CVD incidence rising sharply after menopause suggests protective benefits of ovarian hormones. Estrogen inhibits hepatic lipase, so decline in endogenous estrogens in the menopausal transition may adversely affect lipid levels and subsequently cardiovascular risk. The menopausal transition is associated with declines in HDL cholesterol and increases in LDL cholesterol, as well as changes in HDL composition, which may subsequently contribute to atherosclerosis. In the prospective cohort of Nurses' Health Study, a shorter duration of reproductive lifespan was associated with a higher risk of stroke, as well as CVD, which was likely driven by earlier age at menopause that occurred either naturally or surgically. Another risk factor is use of hormonal contraceptives. Hormonal contraceptives, including oral, transdermal, and vaginal formulations, are effective and are used worldwide by more than 100 million women. There are various formulations containing either combined estrogen and progestogen or progestogen alone, administered as pills, patches, and rings. Although hormonal contraception is common, its use varies. It is less than 10% in developing countries to more than 25% in Europe. In USA, 4 of 5 women have taken the oral contraceptive pill. Combined oral contraceptives comprising of both estrogen and progestogen are thrombogenic and historically have been associated with increased risk of CVD. Oral estrogens have a dose-response association with risk, and doses have declined since their introduction in the 1960s. Most combined oral contraceptives now contain less than 50 microgram, and some contain as low as 15 microgram of estrogen. Crude incidence of stroke associated with hormonal contraceptives is very low. It is 21.4 per 100,000 person years. A systematic review found a 1.7-fold increase in the risk of stroke as a result of combined oral contraceptives use. A 2015 meta-analysis showed that combined hormonal contraception increased the risk of stroke 2.47-fold. Low-dose estrogen was associated with a reduced stroke risk, and progestogen-only hormonal contraceptives were not associated with increased risk of ischemic stroke. When we talk about hormonal therapy, we need to address the use of hormonal therapy in transgender individuals. Gender-affirming hormone therapy aims to align the characteristics of an individual with their gender identity. Transgender females receive oral or transdermal estrogen preparations like estradiol valerate or hemohydrate, often in conjunction with either a gonadotropin-releasing hormone analog or an androgen. The risk of stroke has been analyzed in transgender females who received hormonal therapy. A case control study was performed in 214 transgender females and 138 transgender males with an average of 7.7 years of gender-affirming hormone therapy and mean age of 43 years. Transgender females demonstrated a higher prevalence of transient ischemic attack and cerebrovascular disease, 23.4 per 1,000, which, although no different from age-matched cisgender females, the number here was 14.9 per 1,000, was significantly higher than age-matched cisgender males, with 9.4 per 1,000. No cases were observed in cisgender males. Another cohort study was performed using the electronic medical records of 2,842 transgender females and transgender men. Transgender females had higher rates of ischemic stroke compared with corresponding rates in cisgender men and cisgender females. Ischemic stroke rates were highest in a sub-analysis of 853 transgender females who initiated hormonal therapy during the study period. These rates did not differ compared with cisgender populations during the first 6 years of follow-up, but then increased substantially compared with both cisgender men and cisgender females. Transgender females appear to be at higher risk of developing ischemic stroke compared with cisgender populations. This risk is most evident in longer-term estrogen use. Conversely, transgender men do not have increased cerebrovascular disease risk. Hormone replacement therapy is thought to be vasoprotective owing to the protective properties of estrogen, although this hypothesis has not been confirmed. A pooled analysis of results from randomized controlled trials of stroke prevention from the past 2 decades has even suggested a 30% increase in the risk of stroke in women who receive hormonal replacement therapy, in contrast to the apparent protection of hormone replacement therapy against cardiovascular disease that has been found in large observational trials. A higher risk of stroke is also associated with a longer duration of continuous use of hormone replacement therapy. After 3 years of hormone replacement therapy use, the risk of stroke increases from 6 to 12 per 1,000 treated women. After 7 years of hormone replacement therapy use, the risk of stroke increased to 25 to 40 per 1,000 women. Results from the observational and interventional studies of hormone replacement therapy are different. In the observational studies, hormone replacement therapy was initiated at the onset of menopause, and women in randomized controlled trials were enrolled a decade or more after menopause. This discrepancy has led to the timing hypothesis, which proposes that hormone replacement therapy has different effects on the cardiovascular system at different ages and stages of cardiovascular health. Potential vasoprotective effects of estrogen include beneficial effects on the vascular endothelium and on cardiovascular disease risk factors. This idea led to studies investigating cardiovascular health in women early after menopause, with a focus on atherogenesis as an endpoint. But no substantial effect of hormone replacement therapy on increase in carotid artery intima media thickness was documented. Initiation of hormone replacement therapy 6 to 36 months after last menses did not affect carotid intima media thickness compared with placebo during a 48 months of follow-up. In the ELITE trial, hormone replacement therapy initiated within 6 years after menopause led to a significantly smaller increase in carotid intima media thickness after 5 years follow-up than did initiation of hormone replacement therapy 10 years or later after menopause, independent of progesterone treatment. This data suggests that early initiation of hormone replacement therapy could be associated with a lower risk of stroke than later initiation. So in summary, it is important to be aware of stroke risk factors specific to women. Specific considerations should be optimal stroke prevention strategies: migraine with aura, pregnancy and the peripartum period, endogenous hormone levels, and exogenous hormone therapy. Further research to determine whether risk prediction models should include risk factors specific to women, including hormonal and reproductive exposure, is needed. The take-home messages are the following. Blood pressure is poorly controlled in elderly women. Women are less likely to be on statins and have LDL controlled, and women are less likely to be prescribed oral anticoagulants, and they receive lower doses of NOACs. Women with migraine with aura, users of combined oral contraceptives, and active smokers have a dramatically elevated risk for stroke. Non-hormonal and progestogen-only methods of contraception should be considered in high-risk patients. In pregnancy, eclampsia and preeclampsia are strongest risk factors for stroke. The risk is potentiated by pre-existing genitourinary tract infection, hypertension, prothrombotic states, coagulopathies, and PFO. Early and late menarche increases the risk of stroke. Early menopause increases the risk of stroke. Combined oral contraceptives are thrombogenic and they increase the CVD risk. Stroke risk is most evident in longer-term use of gender-affirming hormone therapy in transgender women. Early initiation of hormone replacement therapy could be associated with a lower risk of stroke than later initiation. Future research priorities are that data regarding stroke in women should be collected in all countries in order to develop specific actions tailored to each society structure and healthcare system. Major gender differences in presentation of stroke and the effect of risk factors suggest a possible benefit of personalized medicine, including investigation and treatment for women with stroke. More evidence is urgently required regarding the effects of treatment interventions in elderly women with stroke, particularly in stroke that is related to hypertension, atrial fibrillation, and dyslipidemia. Early detection and treatment of hypertensive disorders of pregnancy should be promoted. We should investigate interventions to decrease migraine frequency and prevalence in relation to stroke risk, and also analyze the effects of endogenous and exogenous hormones on stroke risk. And I thank you for your kind attention.
Thanks, Anita, for your clear and complete presentation. So we will move on to the next speaker. Next speaker is Dr. Ana Caterina Fonseca. She's based on neurology department in the Hospital de Santa Maria Institute of Molecular Medicine, Faculty of Medicine in Lisbon, and she will talk us about primary prevention of stroke in women.
With primary prevention aims is to prevent the onset of disease before there is any evidence of the condition by addressing the underlying determinants in the population. And we know that women have a 20% lifetime risk of stroke, and also that the majority of stroke-related deaths occur in women. Therefore, reducing the burden of stroke in women through primary prevention should be a goal of public health. There are two main strategies that can be followed to achieve primary prevention. An individual level, also known as high-risk strategy, where the preventative strategy seeks to identify a risk set of individuals to offer them some individual protection, and the population level, also known as mass strategy, that aims to reduce the mean level of determinants of disease and thereby the incidence of disease in the population as a whole. This prevention pyramid shows different risks of different strategies. Population level strategies, like the name itself states, are directed to the population and are always implemented by governments. They aim to tackle social determinants of health, like illiteracy, poverty, urbanization, pollution, and adult child nutrition. They can do that by fostering policies directed to smoking, alcohol trans fat consumption, healthy food consumption, or physical activity enhancement. They form the basis of the pyramid as they are directed to the highest number of individuals. Individual level strategies are higher up in the pyramid, and they are directed to a smaller number of individuals and they aim to control risk factors mainly. Risk factors in this case like smoking, hypertension, lipids, or diabetes, for example. So what the individual level can do is identify people at high multifactorial risk. And guideline-driven management of hypertension, cholesterol, and diabetes is required. Success strategies to improve adherence to healthy lifestyles and drug therapies is also essential. In order to adopt an individual-level strategy for primary prevention of stroke in women, we need to know which one are stroke risk factors in women. And it can be broadly divided into three groups. Those that are women-specific, like pregnancy, preeclampsia, diabetes, or contraceptive use, or postmenopausal hormonal use. Those that are stronger or more prevalent in women, like migraine with aura, atrial fibrillation, diabetes, or hypertension. And those that have a similar prevalence to men and an unknown impact, like physical inactivity, age, prior cardiovascular disease, diet, smoking, obesity, or metabolic syndrome. So what I'm going to do now is to address each one of these three categories of risk factors for stroke in women, and I'm going to tell you what you currently know regarding primary prevention and the control of these vascular risk factors. There's something that you should bear in mind since the beginning, is that most data that was used to develop specific evidence-based guidelines for stroke prevention in women were derived from coronary heart disease studies, that in most studies, therefore, stroke was a secondary outcome, and that women were underrepresented in stroke prevention trial cohorts. So regarding women-specific risk factors, what do we know regarding primary prevention of stroke? We currently know that adverse pregnancy outcomes defined like hypertensive disorders of pregnancy, including chronic hypertension, gestational hypertension, preeclampsia, eclampsia, HELLP syndrome, gestational diabetes, etc., are associated to higher risk of stroke later in life. And therefore, the American College of Obstetrics and Gynecology recommends that women with an adverse pregnancy outcome under cardiovascular risk factors undergo cardiovascular risk screening within 3 months postpartum. We now know that preeclampsia doubles the risk of stroke in later life, and because of the increased risk of future hypertension and stroke 1 to 30 years after delivery in women with the story of preeclampsia, the American guidelines for primary prevention of stroke in women consider it reasonable to consider evaluating all women starting 6 months to 1 year postpartum, as well as those who are past childbearing age, for a history of preeclampsia, eclampsia, and documentary history of preeclampsia or eclampsia as a risk factor, and to evaluate and treat for cardiovascular risk factors including hypertension, obesity, smoking, and dyslipidemia. An interesting study was recently published by Miller Neurology. It explored the issue of potential stroke risk reduction in women who had a hypertensive disorder of pregnancy. They analyzed data from the California Teacher Study, a prospective cohort study, and they explored the relationship of prior hypertensive disorder of pregnancy and later stroke and the interaction of this association with aspirin and statin use. They found that the history of hypertension during pregnancy independently increased the risk of future strokes. In addition, they found that aspirin use reduced the risk of subsequent stroke, especially stroke occurring before 60 years of age, and that aspirin did not increase the risk of recurrent hemorrhage in this population. No significant association was found for statin use. Although this cohort has many limitations, this further raises the hypothesis that women who had an hypertensive disorder pregnancy might benefit from private prevention therapies related to stroke. More studies are needed to confirm these findings. Regarding hormonal contraceptives, they are an effective form of birth control. However, they should be used with caution. The American Heart Association guidelines for private prevention of stroke in women indicate that oral contraceptives may be harmful in women with additional risk factors, like cigarette smoking or prior thromboembolic events. Among oral contraceptive users, aggressive therapy of stroke risk factors may be reasonable, and routine screening for prothrombotic mutations before initiation of hormonal contraception is not useful. And because hypertension doubles the risk, measurement of blood pressure before initiation of hormonal contraception is recommended. What about postmenopausal hormonal use? Well, we know that menopause is associated with increased stroke risk and that 10 years after menopause, stroke risk doubles. This may have been attributed to the loss of estrogen, estrogen, and menopause. And this years ago to the hypothesis that if you could give those estrogens in the form of postmenopausal hormonal therapy, mainly that could decrease risk of stroke. But what studies have shown is that actually postmenopausal hormonal therapy increases the risk of stroke and of venous thrombosis. Therefore, currently, hormonal therapy should not be used for primary prevention of stroke in postmenopausal women. Also, that selective estrogen receptor modulators such as alloxifene, tamoxifen, or tibolone should not be used for primary. And what about risk factors are stronger or prevalent in women than in men? These include migraine or hypertension and atrial fibrillation. Regarding migraine with R, because there is an association between higher migraine frequency and stroke risk, the American Heart Association guidelines for primary prevention of stroke in women state that treatments to reduce migraine frequency might be reasonable, although evidence is lacking. And also, because of the increased stroke risk seen in women with migraine headaches with aura and smoking, it is reasonably strongly recommended smoking cessation in women with migraine headaches with aura. Regarding hypertension, it is the most common modifier risk factor for stroke in both women and men. It has the highest population attributable risk, and women compared to men may have a higher risk of first stroke with hypertension. Therefore, early and sustained treatment of hypertension is critical. Postmenopausal women are more likely to experience a non-dipping nighttime blood pressure pattern, and therefore women might derive more benefit from blood pressure control using ambulatory blood pressure measurement as opposed to conventional blood pressure monitoring. A meta-analysis of 31 large randomized blood pressure trials showed that treatment of hypertension in women aged more than 55 years old was associated with a 38% risk reduction in fatal and non-fatal cerebrovascular events. Therefore, women benefit significantly from this intervention as men. Regarding what type of drugs that should be used to control hypertension, what study shows that the type of medication used to lower the blood pressure may be less relevant than the achievement of targeted blood pressure goals. The only drugs that probably should not be used as first-line agents are alpha-1 antagonists. The recommendations for blood pressure treatment to prevent stroke are currently the same for women as for men. Currently, there is insufficient evidence to warrant a different approach to blood pressure treatment in women from that used for men. The existing guidelines for measurement, identification, and measurement for blood pressure in adults should be followed. Different organizations have established different guidelines and differ slightly into values that they establish as threshold to start to treat blood pressure. Also, the number and the time intervals for blood pressure evaluation differ according to the organization. Here you can see the ones that were established by the European Society of Cardiology, and here the ones that were established by the American Heart Association. Currently, there is no evidence that there are differences in the response to blood pressure medication between the sexes. However, in large-scale reviews that examined the efficacy of antihypertensive drugs, there was no mention that sex-specific efficacy endpoints are evaluated. Perhaps thiazide-diuretic agents may be beneficial agents in older women due to their effect in reducing calcium excretion and preventing osteoporosis. In order to have efficacy, the drugs should be taken according to what they were prescribed. Therefore, it is very important to ensure medication adherence. And one of the factors that decreases adherence to medication is the presence of side effects. We know that side effects tend to be more frequent in women than in men regarding antihypertensive drugs. Therefore, side effects like diuretic-induced disturbance of electrolyte concentration, angiotensin-converting enzyme inhibitor-induced cough, and calcium channel blocker-related dependent edema are more prevalent in women than in men. What we should do is actively ask the patient for these side effects, and if they are intolerable, then medications should be changed for the class of antihypertensive drugs. There are specific drugs that can be used in pregnancy. The ones that are related to the renin-angiotensin and aldosterone axis are contraindicated because they are teratogenic. They include ACE inhibitors, the angiotensin receptor blockers, and the renin inhibitors. A reduction in salt intake can also help to control blood pressure levels. A recent meta-analysis showed that even a modest reduction in salt intake for more than 4 weeks led to significant and important increase in blood pressure in both hypertensive and normotensive individuals irrespective of sex. Therefore, a reduction in salt intake to less than 2,300 milligrams is currently recommended. The recommendations regarding diabetes management for prevention of stroke are currently similar for both women and men. However, there appear to be some sex-specific effects of pharmacotherapy for diabetes. Namely, glucagon-like 1 peptide-1 receptor agonists have better glycemic control among men than women. However, women showed more weight loss. Thiazolidines appear to have better glycemic reduction in obese women, whereas non-obese men responded better with sulfonylureas. Considering atrial fibrillation, the American Heart Association guidelines of primary stroke prevention of stroke in women indicate that considering the increased prevalence of atrial fibrillation with age and the higher risk of stroke in elderly women with atrial fibrillation, active screening, particularly of women more than 75 years of age in primary care settings using pulse taking followed by an ECG as appropriate is recommended. Also, that oral anticoagulation in women aged less than 65 years old with atrial fibrillation alone, this means no other risk factors, women with SHADS2 equal to 0 or SHADS2 VASC equal to 1 is not recommended. They also indicate that new oral anticoagulants are a useful alternative to warfarin for the prevention of stroke and systemic thromboembolism in women with paroxysmal permanent atrial fibrillation and pre-specified risk factors. The European Society of Cardiology guidelines are a little bit different and they recommend anticoagulation for SHADS-VASC equal to 1, leading therefore to the recommendation of anticoagulation for all women with atrial fibrillation. Although NOACs have shown efficacy for stroke and systemic embolism prevention in both women and men, there appear to be some differences. Women treated with NOACs had a lower rate of major bleeding in the clinical trials and a slightly higher rate of stroke and systemic embolism compared with men. In the future, understanding the pathophysiological mechanisms that cause women to have higher risk of stroke and atrial fibrillation may help us to design better primary prevention strategies. And what about the risk factors that have a similar prevalence in women and men? Primary prevention measures regarding dyslipidemia are similar in women and men. There is no indication for primary prevention for women between 40 to 65 years of age if they are at low risk, and we should bear in mind that pregnant women or women intending to get pregnant in the next 1 to 2 months should not take statins. There seem to be, however, some differences regarding the adherence of both men and women to statins. This study evaluated patients that were included in a registry, patients that were prescribed statins for either primary or secondary prevention. It included 5,693 patients. What was shown was that the recommended statin treatment, women were less likely than men to be prescribed any statin therapy or to receive a statin at the guideline recommended intensity, and also that women were more likely to report having previously never been offered a statin therapy, declined statin therapy, or discontinued their statin. So this study showed that women have a higher probability of experiencing any side effects when taking statins. It also showed that women have a higher probability of stopping a statin because of a side effect. And when offered an alternative, a statin, they are less willing to try that statin. This is in accordance to data international consensus statements that also recognize female sex as a risk factor for statin-associated muscle symptoms. You know what about using aspirin for primary stroke prevention in women? Well, the American Heart Association guidelines for primary prevention of stroke in women that were published in 2013 stated aspirin therapy with a dose between 75 and 335 milligrams per day is reasonable in women with diabetes unless contraindicated. And if high-risk women, this means that one with a 10-year pruritus cardiovascular risk superior to 10 as indication for aspirin but is intolerant of aspirin therapy, clopidogrel should be substituted. They also state that aspirin therapy can be useful in women more than 65 years of age if blood pressure is controlled and the benefit of ischemic stroke and myocardial infarction is likely to outweigh the risk of gastrointestinal bleeding and hemorrhagic stroke. However, the data that we have regarding antiplatelet treatment for primary prevention of cardiovascular disease has evolved over the last years. And some of the randomized clinical trials that were published more recently did not replicate these findings. These clinical trials include the RIF trial and the SEND trial. In the RIF trial, that included used a dose of 100 milligrams of aspirin for primary prevention, did not show a significant effect of aspirin. Indeed, the event rate was much lower than expected, which was probably reflective of contemporary risk management strategies, like more tight controlled blood pressure and use of sedatives. So it probably makes it more representative of a low-risk population. And the role of aspirin in primary prevention among patients at moderate risks could not therefore be addressed in these randomized clinical trials. Nevertheless, findings with respect to aspirin effects are consistent with those observed in previous published low risk prevention studies. In sub-analysis regarding gender that was done in the RIFE trial, women did not benefit from aspirin for primary prevention. In the ACCENT trial, aspirin use prevented serious vascular events in persons who had diabetes and no evident cardiovascular disease at trial entry, but it also caused major bleeding events, and the absolute benefits were largely counterbalanced by the bleeding hazard. What do we know regarding obesity, metabolic syndrome, and lifestyle factors? Well, in the human health study, a healthy lifestyle profile was defined as never smoking, alcohol consumption between 4 and 10.5 drinks per week, exercise more than 4 times per week, BMI less than 22, and a diet high in several fiber, folate, omega-3 fatty acids with a high gravity of polyunsaturated to saturated fat and low in trans fat and glycemic load. And what was shown was that women with highest score on this scale had 55 lower risk of stroke than women with the lowest score. Therefore, the guidelines recommended all women, regardless of risk, should be counseled on lifestyle recommendations like smoking cessation, heart healthy eating patterns, regular physical activity, and weight management. This is an important point because we usually tend to think about mainly pharmacological measures to achieve primary or secondary prevention, but non-pharmacological measures are also very important. Not only individual level strategies, but also population level strategies with the adoption of policies and mass media campaigns aimed at women and reinforcing the idea of a healthy lifestyle have an important outcome here. Another very important point that can be addressed by both population level strategies and individual level strategies is improving medical education, increasing the knowledge that the population has regarding what determines disease, what causes it, and what are the risk factors. Therefore, it's very important to design and launch campaigns that aim to increase the knowledge of the public regarding what determines health or disease, or what are risk factors. In the past, similar campaigns have been shown to be cost-effective, and they might be able to lower the global incidence of cardiovascular events by as much as 50%. In the last years, some campaigns have been directed to women, for example, this one from the World Stroke Campaign. This one, for example, from the CardioSmart org, aimed to let women know that specific pregnancy problems could lead to higher risk cardiovascular disease in the future. And this one from the American Stroke Association highlights the risk factors for stroke. To conclude, primary prevention is an essential component to fight to reduce the burden of stroke in women. There are different strategies that can be used, either individual level approach or population level approach. In the individual level approach is the need to monitor risk factors. We still need to know what will be the real benefit of using apps and health gadgets for this setting. It's very important to promote healthy lifestyles, which can be done either at individual or population level. It's very important also so that we can have more evidence to inform our decisions for primary prevention, that future studies report data separately for men and women, stratifying by age when examining sex differences in disease rates.
Thanks, Katarina, for this clear and inclusive presentation. We have 10 minutes left for the discussion, and in the question and answer box, we have few relevant questions. The first question is for Anita. What is the strategy for education and prevention among women in North Macedonia?
Well, thank you very much for this question, Dorina, and hi to everyone who is watching. I'm really happy that we have such a positive feedback from the audience. So this is an excellent question. So basically what we are doing is that we are using specific days, for example, the European Stroke Awareness Day, and also the World Stroke Campaign, the World Stroke Organization that is organizing every 29th of October for raising stroke awareness. And we are actually together with my colleague from our SSO and also from the professional organization that we have created this year for stroke. We basically have a lot of campaigns and together with my colleague Maya, we have also a project. So we are actually assessing the risk factors, not just in women, but also in the population. And we are actually measuring the degree of stroke risk according to the presence of the stroke risk factors. So basically through our campaigns, we are trying to educate our population, and I'm aware that we need to do more work. Basically, I could just mention that I was a mentor of a candidate from the Clinic of Gynecology recently, and the topic that we evaluated for her PhD was actually the assessment of intima media thickness in postmenopausal women. And we actually found a lot of interesting results. For example, increased intima media thickness in obese women related to their hormonal status, relating to the other problems that they had in the postmenopausal period. So that way we are also trying to raise awareness that it is actually very important to have a multidisciplinary approach when we are assessing stroke risk factors in women, because sometimes women encounter that they have some problems, actually stroke risks, when they go to a gynecologist. So they are not assessed by their general practitioner, or they have not gone to see a neurologist. So that is why that we need to have a multidisciplinary approach, not only by professionals, healthcare workers, but also we get a lot of support from the stroke support organization. So we involve everyone when we want to actually improve something in our society.
Thanks, Anita. Very interesting answer. Very interesting example of application of several tools for prevention and awareness in the country. So we have another question. Maybe Katarina could start answering. And the question is, why only migraine with aura is associated with an increase in cardiovascular risk?
I have to turn it on, sorry. So probably migraine with aura is a different kind of mechanism. It possibly also involves a difference into the endothelium vessels from the posterior circulation, and therefore those patients might be in higher risk of stroke. Also, there's a very ongoing debate that still continues regarding if these patients have higher probability of having a PFO, patent foraminal valve. That could also be a possible mechanism. There's a lot of discussion going on regarding that, but it's also a possible mechanism to explain increased risk of stroke in these patients.
In the chat, there is a comment, interesting comment about the possibility to use progesterone pills instead of estrogen pills in women with the migraine with aura at high cardiovascular risk.
Well,
yes, it is. Oh, sorry. It is important actually to assess the risk in those patients. And as we stated in our lectures, the risk is increased in patients with aura, in patients who have migraine with aura and use combined oral contraceptives, and the ones who smoke, the risk is dramatically increased. So we have to take into account all these stroke risk factors. and then modify the hormonal therapy according to their stroke risk factors. So yes, only progestogen hormonal therapy. I mean, it should also be in advice with the gynecologists.
Okay, the attention of the audience is moving to the pregnancy period. And another question is, do you recommend statin as primary or secondary prevention of stroke in pregnancy?
Well, statins are contraindicated in pregnancy, and if a woman intends to get pregnant, should stop taking their statins 1 to 3 months prior. So they are contraindicated.
So we could continue with pregnancy, and one interesting question could be for Anita, but also for Caterina, the field of use of IVT in pregnancy.
Oh, well, the use of IVT in pregnancy, we have data for the use of IVT pregnancy. Actually, it is less used in patients who have stroke and who are pregnant compared to non-pregnant patients. Actually, pregnancy is a relative contraindication for IVT. Possible complications include intracerebral hemorrhage, systemic bleeding, and anaphylaxis. And although the alteplase does not cross the placenta, some concerns surround the use of this drug in pregnancy, particularly regarding the potential for placental hemorrhage. So basically, the use of thrombolysis in pregnancy and postpartum has been reported in over 200 cases, but the problem is that pregnant women have generally been excluded from all randomized controlled trials. So actually, current guidelines from the American Heart and Stroke Association state that intravenous administration of RTPA may be considered in pregnancy when the benefits of treating moderate or severe stroke outweigh the increased risk of uterine bleeding. Because although, as I said, alteplase does not cross the placenta, there is a theoretical risk of placental bleeding and intrauterine fetal death.
Thanks, Anita. Thanks for your complete answer. And we have another more general question about the different efficacy of antiplatelet and anticoagulant drugs in women in primary and secondary prevention.
Yes, so studies show that newer anticoagulants are as efficacious in women than in men. So the efficacy is similar. However, when we go and see in the meta-analysis the overall results regarding, for example, security, we find that women have a less probability of having major hemorrhage with an OAC. Don't have an explanation why that happens, but it's true. They have a smaller probability of bleeding. And regarding efficacy, what we can see is that regarding the same level of anticoagulation, men have a smaller probability of having an infarct. And that is also in line what we know regarding the increased risk of stroke in women with atrial fibrillation. And it's also reflected in the CHAD score. So we really don't know why women with atrial fibrillation tend to have high probability of having strokes and having also more severe strokes. But it is also reflected in the data that we have regarding patients that are under anticoagulation. So all of them should be anticoagulated, both men and women, but there seem to be small differences between them. And it's a good notice that it seems to be safer in women also regarding major bleedings. Regarding antiplatelets, data has changed a little bit in the last years. So the initial studies that were done in patients with a higher risk of subsequent stroke show that women probably benefit more than men from primary prevention with a small dose of aspirin, 75 to 100 milligrams of aspirin. And the initial guidelines stated that women with more than 65 years old of age could do aspirin as a primary prevention measure. Well, lately, in more recent trials, show that these differences in efficacy in this smaller effect that we were seeing in women was not reproduced. And there are several explanations for this. One of the possible explanations is probably that nowadays the risk of having a stroke is already lower than it was some years before. Because why? Because currently we have a more intense prevention strategy. More patients are in the treatment with statins, for example, and more patients are also have a higher probability of having their blood pressure controlled. So probably nowadays, these patients that are being included in clinical trials have a lower risk of having a stroke. So they are a low risk population. And therefore, probably the effect that we were initially seeing in the past cannot be demonstrated. So currently, probably some scientific societies state that in general, we should not start aspirin as a primary prevention measurement. But there's still some doubt regarding the patients that have a higher risk of having a stroke. So there's some debate going on right now if aspirin should be banned as a primary prevention measurement for all patients, or if we still should use it in selected patients with a higher risk of having a stroke.
Okay, thanks, Katarina. We have two last questions about further stratification of stroke risk in women. One question is about stroke stratification according to the race, but I think we don't have really definite answer to this question because of the lack of data. And the last question is the stratification of stroke in women according to age, with a special focus to young stroke patients. So the question is, what strategies can be implemented to reduce the number of stroke in young adults?
Basically, we can divide stroke risk factors in women in 3 periods of women. The first one should be the young women and women in reproductive age, and they have their specificities. And then we can the other group is women over 80 years of age who also have specific risk factors. So basically what we should do is to have a multidisciplinary approach. And basically, I think that we should include data about the reproductive health in all our patients, in all female patients, because it is very important to assess all this data. As I mentioned in my lecture, so we should assess age at menarche and other possible hormonal disturbances, then use of hormonal contraceptives, which is very important in younger women, and also presence of migraine with aura. And in pregnancy and in the postpartum period, we should assess hypertensive disorders of pregnancy, so preeclampsia and eclampsia, and gestational diabetes. And I would add also in women that are older than 80 years, I didn't mention that in my talk, but it is very important to assess psychological, psychosocial factors and depression.
Thanks, Anita, for pointing out also the needs of prevention in elder women. I think we have not enough time for other questions and answers. So we can leave the lucky question for the next webinar, maybe on elderly women or pregnancy, for example. And I would thank Anita and Katarina for their excellent presentation. We had very positive feedback from the audience, and I hope this webinar could be accessible also after this morning, in order to make more questions and to reason about these problems. Also contacting the speakers by private message if needed. Do we agree?
I would like also to thank you very much for the wonderful discussion. Absolutely, I agree, and I confirm that the recording will be available on the WSO website. And of course, all further questions will be sent to the speakers for responses. Thank you very much for joining, and I wish you a very nice day.
Thank you.
Thank you. Bye-bye.
Bye. Bye-bye.